My topic is fluid responsiveness in ICU. So today we are talking about fluid responsiveness in ICU, and I think why we are discussing this particular topic is because we know that hypovolemia and hypervolemia both are detrimental for a patient in either in ICU or operation theater. And we also know that over 1,000 years, our body is acclimatized so that there were like a lot of heat, drought, and in the thousands of years ago, when it was like patients were like trauma, a lot of war, and their body was little acclimatized to the hypovolemic phase. But this hypervolemia is created by our medical science, and for that, body is not fully equipped. And we all know that because of hypervolemia, there is increased hydrostatic pressure, and which can cause pulmonary edema or, for that matter, interstitial edema, and sometimes it may give us like some stormy course in the ICU that can cause prolonged ICU stay and mortality. So, because of this hypervolemic phase, there is cardiac filling pressures are increased, and there is a phase like that can cause damage to the endothelial glycocalyx layers and edema formation, which again cause interstitial edema and LVF. We all know that this is a Frank-Starling curve. There is a preload and the steep portion of this curve. When we give fluid, there is a adequate increase in stroke volume. But at the same time, when the patient is on the flat portion of this Frank-Starling curve, there is not much rise in stroke volume, and contrarily, there is a extra volume lung water in phase. And this Mark Felix curve shows that when patient is on the flat portion of this curve, then there is not much of a rise in stroke volume, but contrarily, there is a rise in extravascular lung water, and then that can cause a pulmonary edema. So we all know that fluid overload is like detrimental for ICU group of patients, and there is enough evidence about fluid overload causing a lot of problems in the ICU. And day in and day out, when we work in ICU, we all know that we take care of a lot of aspects in the ICU, like managing antibiotics, vasopressors, nutrition, but we give less value to the, I think, for fluid part. Whenever our patient is, for that matter, lower normal blood pressure or lower normal urine output, we tend to give fluid challenge that give him or her 400 ml of fluid. That's our knee-jerk reflex. But I think we should treat fluid as a drug, like any other drug. When we see indication, contraindication, and dosage, that's how we should treat as a fluid, because it is an integral part of ICU management. And we also know that when there is a patient who is having same quantity of contractility, preload or afterload, and when we give some fluid to this group of patients, they behave differently. So there is a individual variability in the relationship between cardiac output and preload. And we also know that whenever we give fluid, about 500 ml of fluid, there is an increase in cardiac output that should cause a rise in cardiac output by 15%. So we'll go through a few cases. That is, first is 35-year male presents with acute gastroenteritis with diarrhea up to 8 times in a day for past 4 days, with heart rate 136, blood pressure 80/50, saturation normal on room air, and urine output 15 ml per hour, and lactate is 4. So this is the first case. And second case is 60-year male, background of IHD, moderate LV dysfunction, CKD, infective exacerbation of COPD. There is bilateral wheeze. He's hypoxic, tachycardic, hypotensive, and he's also dropping his urine output to 10 ml per hour, and lactate has gone up to 4. So these are two cases. And we all know that this first case, when there is a young male, he is obviously having hypotension because of diarrhea, and there is not much of like history, and there are no other comorbidities. And this patient will tolerate fluid definitely, as and the cause of his hypovolemia is fluid loss from his GI tract. On the other hand, the second case is having a lot of comorbidities: ISD, LV dysfunction, CKD, he's hypoxic, he's tachycardic, he's elderly. So we don't know how much fluid he will tolerate, which kind of fluid he will require, and how will he behave after giving a fluid challenge or fluid bolus. So for that matter, we have to have this Frank-Starling curve, and this particular curve denotes that whenever we give a fluid challenge or preload, for that matter, there is a proportionate rise in stroke volume when patient is having good LV function. But when patient is having decreased ventricular function, on that part, even if we give a fluid bolus or preload, there is not much of increase in stroke volume, and contrarily, there is a increase in hydrostatic pressure, and that can cause a pulmonary edema, LVF. On this aspect, on this part of this curve, if we give fluid, there is a chance that patient may deteriorate. And contrarily, when our young patient who is hypotensive because of fluid loss, if we give fluid, he's on this steep part of this curve. He's having normal ventricular function, our first young patient. he's having normal ventricular function and he will tolerate fluid much better, unlike because of other elderly patient who is having a lot of comorbidities. So what are the measures of fluid responsiveness? There are static measures and dynamic measures. Static measures are CVP, global end diastolic volume, pulmonary capillary wedge pressures, IVC diameter, and dynamic measures are pulse pressure variation, stroke volume variation, end expiratory occlusion test, tidal volume challenge test, and IVC variability. We'll go step by step. We all know that CVP is very traditional way of measuring fluid responsiveness or preload, and there are a lot of factors which can affect central venous pressure measurement in the ICU. Initially, we used to measure central venous pressure with the help of fluid column and scale, and it is invalid now. And there are a lot of other factors which can affect CVP. The central venous blood volume, central venous vascular compliance. Whenever there is increased compliance, you may get erratic readings of CVP. There is change in intrathoracic pressure. Our ICU patients are like when they are in respiratory distress, tachypnea, or they are on ventilator, there is a lot of intrathoracic pressure changes, and that can cause change in central venous pressure also. Whenever there is a tricuspid valve dysfunction, that can cause change in your CVP values. And sometimes measurement techniques, our ICU staffs, whenever they measure CVP with crude method like using fluid column and scale, that can give a erratic reading. We also know that when to measure CVP, whenever we are measuring CVP, we should measure at the end of diastole and at the end of expiration. This is a monitor showing CVP trace where we have all these A wave, C wave, V wave. And whenever we see that this particular stress in our ICU, we should know where to calculate as our central venous pressure. If we take other point wherein we will see that CVP is 5, at other point it is 10, but we should remember that we should measure CVP at the end of diastole and at the end of expiration. This particular presentation is about 188 patients in ICU group, wherein we have measured central venous pressure on the y-axis, and on the x-axis there is a intravascular volume. Whenever there is intravascular volume with the help of blood or fluid therapy, and intravascular volume is increased, and sometimes whenever patient is hypovolemic, either because of disease per se, from this pictorial presentation we can see that whenever we take any value of CVP, there are equal number of patients having hypervolemia as well as hypovolemia. Suppose we take a CVP of 5, there are patients of having hypervolemia and hypovolemia. So what does it mean? This means that for any given CVP value, there is 50% chance that patient is having hypovolemia, hypervolemia. Though CVP low, or if your CVP is low, there could be patient on hypervolemia, hypovolemia. If your CVP value is still high, there could be patient of hypovolemic or hypovolemic. So there is no data to support the widespread practice of using CVP to guide fluid therapy, and this approach of fluid resuscitation with the help of CVP should be abandoned. This is from the update meta-analysis, does the central venous pressure predict fluid responsiveness or not, from the critical care medicine 2013, where they have studied around about more than 1800 patients from 43 articles, and area under curve was like 50%. So what are the other static measures of measuring fluid responsiveness? These are pulmonary capillary wedge pressure, which measures LV end diastolic volume, and it needs pulmonary artery catheter, and which has same drawback as CVP, and normal value is 4 to 12. Other static parameters like IVC diameter, this particular test we do very often, quite frequently in ICU, where we see IVC diameter and then we judge whether patient is in hypervolemic or hypovolemic. So IVC diameter, it reflects right atrial pressure and more likely demonstrate the relation of right atrial pressure in relation to the intra-abdominal pressure. So again, just looking IVC diameter is not helpful because it may give us idea about intra-abdominal pressure also. And usually we should measure 1 to 2 centimeter caudal to cavoatrial junction, avoiding hepatic veins. So there is a cylindrical effect. If we take proper axis, then only we are able to see whether we are having proper IVC diameter or not. If we take peripherally, then inadvertently we see less IVC diameter. Otherwise, we may end up in giving a more fluid. So these are all static indicators wherein they have principle of that pressure is directly proportional to the volume, and they have linear relationship. But that is not the fact, because there are a lot of other factors affect this volume and pressure as well. And these are all flawed assumptions, as studies has showed. And many times there are incorrect measure techniques in ICU about measuring these static indicators, and evidence shows that they don't benefit the patient. So what are the dynamic indicators? So we should have a dynamic indicators, because static indicators are not reliable. Dynamic indicators gives us an idea about whether our patient is fluid responsive or not, or what happens after giving certain amount of fluid challenge. So these all dynamic indicators use mechanical ventilation induced changes in preload to track the subsequent changes in the stroke volume. So another case, here is a 46-year-old male patient brought to ICU with respiratory distress and hypotension, and he is suspected to have a community acquired pneumonia. His USG IVC shows IVC diameter of 1.6 centimeter, and it is collapsing more than 50%. So what will you do? The option is number one, you can give fluid as he is fluid responsive. Option two is IVC is not reliable in spontaneously breathing patient as a marker of fluid responsiveness. So we all know that these dynamic indicators depends upon the change in intrathoracic pressure, which is caused by respiratory variations. So whenever our patient is on ventilator, that cyclical breathing pattern can cause cyclical change in intrathoracic pressure and volume. And that's why we'll get some sort of variations in the form of pulse pressure variation or a stroke volume variation. Here in this case, as mentioned in the history, that patient is in respiratory distress and patient is spontaneously breathing, though he is hypotensive, though his IVC diameter is less than 1.6 and IVC is collapsing. That guides us that patient is hypovolemic. But given a scenario of respiratory distress and spontaneously breathing patient, this is not a good indicator. So IVC variation, it is easily obtained by using transthoracic cardiac ultrasound, and it cannot be used when tidal volume is low, because low tidal volume causes less disturbance to the intrathoracic pressure, and that's why there is incomplete variations to the intrathoracic volume, and that after that PV as well as SVV. And when lung compliance is low and when there is spontaneous breathing, there is a change in IVC variation, like patient of respiratory distress, patient of COPD. There is a lot of change in compliance of the lung. That's why even though patient is like spontaneously breathing, if he is breathing very hard, that can cause a very drastic change in intrathoracic pressure. And when there is intra-abdominal hypertension, which may impairs the reliability of this IVC index. So IVC variability, though it is a very good dynamic marker of seeing preload or fluid responsiveness, but we have to have like patient should be on ventilator, patient should not be spontaneously breathing, and there should not be much of intra-abdominal hypertension. Then only we can see the IVC variability. So how we see IVC variability? We see minimum diameter with the inspiration and maximum diameter with the expiration, and then we calculate this indices, that is IVC distensibility index, which is maximum IVC diameter during inspiration, IVC diameter expiration, followed by divided by IVC diameter during inspiration. So this particular formula already there, and that will give us idea about what is distensibility index. And there is like already ready-made formulas are there, and we can get IVC variations with the help of this formulae. And when the distensibility index is more than 18%, which is considered as a fluid responsiveness. So how we assess IVC variability? So if our IVC is variable and if our IVC is collapsed and IVC is, then that means only tells us that IVC pressure is below abdominal pressure. That's all. And when patient is on ventilator, or for that matter, patient is breathing very smoothly, there is no stress pattern of breathing, intra-abdominal pressure, then only our IVC will reflect central venous pressure. And IVC is variable as well as CVP is low. That will tell us about a hypovolemic stage or high venous compliance and hyperdynamic cardiac function. So what are the limitations of IVC variations? As mentioned, that technical variations, we have to have a proper window, a proper axis, precision of measurement. Whenever we have a look on IVC with the help of USG probe, and we just see the IVC diameter, and then we make our mind that patient is hypotensive or hypovolemic or hypervolemic. That should not be the proper way. We should have a proper maximum diameter, minimum diameter, and then we should calculate a distensibility index. So patient-related limitations are intrathoracic pressure changes may give a lot of variation in IVC. Right atrial compliance also can cause a lot of variations in IVC, and intra-abdominal rise in intra-abdominal pressure also causes a variation in IVC variability. So there is another like dynamic measures of fluid response, that is pulse pressure variation and stroke volume variation, wherein we can see that there is a cyclical change in stroke volume caused by respiratory pressure changes in thoracic cavity. So in this particular pulse pressure variation, wherein patient is having arterial line in place, and we see the trace of our arterial pulse, that is arterial blood pressure, and we see the maximum pulse pressure variation and minimum pulse pressure variation. Then we'll take how much is the variation. This pulse counter analysis, and which is a complex formula where a different machine uses different kind of algorithm to calculate stroke volume. And because of this particular pulse counter analysis, which is already installed in the various echo monitor, we will directly get the cardiac output. So this is a particular pictorial representation of what happens during when patient is on mechanical ventilation, what happens during inspiratory phase and what happens during the expiratory phase. So whenever there is a positive pressure ventilation, whenever breath is delivered in, there is a rise in intrathoracic pressure because of our lungs are getting inflated. our alveoli are getting inflated, and which causes decrease in right ventricular preload because there is an increase in intrapleural pressure. Intrapleural pressure causes there is a compression effect on the right atrium, and then there is a right ventricular decrease in right ventricular preload. Then right ventricular stroke volume also decreases. So positive pressure ventilation inspiration has a negative impact on right ventricular preload, and on the contrary, it has a positive effect on the left ventricular. What it causes? Because of transmural pressure, there is a decrease in LV afterload, and that's why it causes increased stroke volume variation. So positive pressure causes decreased venous return to the right side of the heart, and positive pressure ventilation during inspiratory phase causes increasing left ventricular stroke volume. And all this is cyclical variations of increase and decrease of stroke volume because of decreased RV preload, increase RV stroke volume. There is a cyclical change in stroke volume variation. Pulse pressure variation is a marker of stroke volume variation. We can get a cyclical increase and decrease amplitude of this pulse pressure variation, and that's how we get change in pulse pressure variation because of decrease in RV preload and decrease in LV afterload. So this particular cyclical change of pulse pressure variation, which can tell us whether our patient is fluid responsive or not. So this green is inspiratory curve expiration, and then this is a stroke volume variation, that is pulse pressure variation. There is an increase and decrease in amplitude of pulse pressure. So whenever there is a such kind of variation in pulse pressure or stroke volume, we can see that our patient is fluid responsive. So these are the already ready-made formulas are available in the monitor, which tells us pulse pressure variation. Pulse pressure variation, PPV, is any monitor in ICU where we just need to have a arterial line, and which can tells us about the pulse pressure variation. For stroke volume variation, we need to have a specialized cardiac output monitor. And what are the prerequisites required for this pulse pressure variation and SVV, stroke volume variation? That patient should be fully mechanical ventilation with no patient efforts. Tidal volume should be like 8 to 10 ml per kg body weight, and patient should be sinus rhythm. So all these criteria usually not fulfilled by the patient in our ICU. Our patient, we want patient to be awake. We want patient to trigger on the ventilator. We want less tidal volume to be delivered, that is less than 6 ml per kg per body weight. Patient may not be in a sinus rhythm always. There is a kind of sometime RV dysfunction. So all these are though it is prerequisite, but it is not ideal scenario in the ICU. And another prerequisite, heart rate to respiratory rate more than 4. That means either patient should not be bradycardic or patient should not be tachypneic. So what should we do? These kind of patients are not present, but still we have to have some sort of cardiac output or pulse pressure variation monitoring in our ICU. So PPV more than 13% more likely represent fluid responsiveness. PPV less than 9% more likely fluid unresponsive, and 9 to 13% gray zone. So again, SVV more than 15% fluid responsive, less than 10% fluid unresponsive, and 10 to 15% gray zone. So what are the limitations of these pulse pressure variation and stroke volume variations? As I mentioned, irregular heartbeats, increased abdominal pressure, spontaneous breathing patients, those will give false positive results, and false negative results will be like low heart rate to respiratory rate ratio, mechanical ventilation with low tidal volume, thorax open, and spontaneous breathing patient. So that's why PPV and SVV have some limitation and some prerequisite required for that, which is like patient should be completely paralyzed, patient should be on ventilator, he should not have spontaneous breathing. So those are all drawbacks while monitoring PPV and SVV, and he should be on high tidal volume because that much tidal volume is required to change in intrathoracic pressure and volume. So what should we do now? So we'll go through another case, that is a 62-year-old male victim of in ICU with ARDS with PF ratio of 140 on control mode of ventilation. Currently BP is 130/87, pulse rate is 116, CVP is 4, and PPV is more than 18. So what will we do? So here in that CVP 4 millimeter is low CVP, pulse pressure variation is 18. That means PPV is more than 13, means patient should be fluid responsive. Looking at these all values, we see that patient should receive fluid. But I think we know that our targets of fluid responsiveness is not achieving only values, but there should be some target to achieve that values. In this particular case scenario, though patient is having ARDS, PF ratio of 140, but patient's blood pressure and pulse rate is reasonably okay. So just looking values, CVP and PPV, we should not land up in giving fluid in this group of patients, as patient is not requiring a fluid, or patient's cardiac output or stroke volume is well maintained in this particular case. So what we should do when our PPV and SVV have some sort of prerequisite So what are the other measures to see for fluid responsiveness? This is end expiratory occlusion test, wherein this is again cardiopulmonary, based on the cardiopulmonary interaction. In this particular test, what we do at the end of expiration, we just hold expiration for a few seconds to prevent the cyclical decrease in venous return and cardiac preload, which increases transiently. So what we do, we put a hold at the end of expiration so that there is no breath delivered, and that's why there is increase in venous return to the right side of the heart, which causes preload challenge, and that can cause fluid challenge, that is preload challenge, which results in a sometimes it results in a rise in cardiac output. And cardiac output rise in this particular test because of end expiratory hold is sometimes such a low that it is sometimes less than 5%, or it is just 5 to 10%, and our cardiac output monitor should be able to pick up this small amount of rise in cardiac output. And this particular test we can do whenever we have a patient on low tidal volume ventilation, patient on cardiac arrhythmias, and patient on spontaneously breathing. So in PPV and SVVV, these are all dynamic markers. When patient is on ventilator, patient completely paralyzed, no cell breathing, and there is no tachycardia, no tachyarrhythmias. But these particular tests we can do in low tidal volume ventilation, cardiac arrhythmia, and spontaneously breathing patients. So as I mentioned, we put end expiratory hold, and then we see how much rise in cardiac output. First, initially we baseline, we monitor cardiac output, then we put end expiratory hold for 15 seconds, and then we again see for rise in cardiac output, and then on the basis of rise in this cardiac output, we then give fluid challenge. So this particular end expiratory occlusion test required cardiac output monitor, and threshold is sometimes very less, that is 5 to 7% or 5 to 10%. And again, evidence is variable. We'll go through another case. In this case, 39-year-old post-surgical patient in abdominal sepsis, severe ARDS, on mechanical ventilation. He has dropped his blood pressure. He's already on tidal volume ventilation, control mode of ventilation with 320 ml, that is 6 ml per kg ideal body weight, and respiratory rate 24 per minute. You have arterial line in situ, and his pulse pressure variation is like 17%. So what will you do? You would give fluid bolus, as he is fluid responsive. You would like to perform tidal volume challenge test and then decide about fluid bolus, since his tidal volume is 8 ml per kg, or increasing tidal volume may be an issue, and hence you will prefer PLR test. So as we have already some challenges while calculating PPV stroke volume variation and end expiratory occlusion test. So low tidal volume ventilation, which is very common in our ICU, managing like all medical or surgical group of patient, we usually put a patient on ventilator with 6 ml per kg ideal body weight. And this low tidal volume sometimes is insufficient to cause change in intrathoracic volume pressure. So all our dynamic indicators are on the basis of heart-lung interaction. So low tidal volume decreases the sensitivity of pulse pressure variation, and sometimes even though patient is fluid responsive, this particular, because of low tidal volume, there is a false negative results, and we may land up in not giving fluids. And sometimes pulse pressure variation more than 13%, even though patient is on low tidal ventilation, that tells us that patient should receive a fluid. So in our case, patient is ARDS, and there was patient is already on ventilator and PPV more than 13, that our patient was fluid responsive. So what is tidal volume challenge test? So low tidal volume is insufficient to produce significant change in intrathoracic pressure. That's why PPV and SVV may induce non-responsive status even in responders, and pulse pressure variation and stroke volume variation do not reliably produce preload responsiveness in patient where we deliver a volume of 6 ml per kg. And that's why there is a tidal volume challenge test, wherein we for transiently we increase our tidal volume setting from 6 ml to 8 ml, and then for about 1 minute, and then we see what happens. And from this particular study, the changes in pulse pressure variation or stroke volume variation after tidal volume challenge reliably predicts fluid responsiveness during low tidal ventilation. And this study tells us that transiently increasing tidal volume from 6 to 8 gives us a fair idea about pulse pressure variation and may unmask the responders. So this is about the tidal volume challenge test when our patient already on low tidal volume ventilation. And this is video. This is our patient wherein pulse pressure variation is 8. PPV is a value of 8 when this tidal volume of 270, that is 6 ml per kg. And transiently then we will increase this tidal volume from 6 ml to 8 ml kg, and then we'll see what happens to the pulse pressure variation. So now we have increased this tidal volume to 6 ml from 6 ml to 8 ml, that is 360. Ultimately, this tidal volume from 6 to 8 causes change in intrathoracic pressure, and that's why there is pulse pressure variation. And our PPV initial or value of PPV of 8 is going up to 13 and then 15. So just by unmasking this PPV, with the help of tidal volume challenge for 1 minute from 6 to 8 will give us a fair idea about pulse pressure variation. So this very nice pictorial presentation, how should we proceed, how to identify a patient of preload responsiveness or not. Patient on mechanical ventilation with no spontaneous breathing, no cardiac arrhythmia, will calculate PPV with the help of just arterial line, and our monitor will give us a PPV. When PPV is more than 13%, that means patient is a fluid responsive, and we should give fluid. And in case of doubt, we should do a passive leg rising test. And when there is a decrease in PPV, fluid responsiveness is likely, and when there is no decrease in PPV, fluid response is unlikely. And whenever our patient is having PPV less than 9%, the pulse pressure variation less than 9%, we should go with a tidal volume challenge test. Increase your tidal volume from 6 to 8 and then see whether our patient is a fluid responsive or not. And in spite of, whenever there is like already patient is on ventilation, where patient is already put on tidal volume more than 8 ml per kg, then see how is your PPV and then assess for fluid unresponsiveness. When your patient is less than 8 ml per kg, then increase to 8 ml per kg, that is tidal volume challenge test. And whenever patient is spontaneously breathing or in cardiac arrhythmia, then do not take PPV into account and consider other tests as marker of fluid responsiveness. So this is what we do usually in our ICU, that we all are having transthoracic echo machine in ICU, and then we see what is LV VTI variability, wherein we obtain VTI, that is velocity time integral variations, that is left ventricular output. First, initially we calculate LVOT diameter, and then we LVOT diameter in parasternal long axis view. Then we obtain a apical 5-chamber view where we put a cursor on LVOT, and then we obtain a velocity time integral. On the basis of these VTI variations, we can assess whether our patient is preload responsive or not. VTI variation more than 12% suggests patient of fluid responsiveness. So LVA VTI variation with passive leg rising test. So again, this is another combination of two tests, that is LV VTI variation and passive leg rising test. So what we do, again, we obtain a VTI in apical 4-chamber view, and then after that we lift both lower leg to 45 degree, and after 1 minute we see what is the variation. If there is a increase in VTI by more than 12.5%, that predicts increase in stroke volume by 15%, that is 500 ml over 15 minutes. So LV VTI along with passive leg rising test, and it has sensitivity of 77 and specificity 100%. So what are the drawbacks? It has inter-observer variability, same visit like other dynamic indicators, and it has a snapshot and not continuous, and it has resource intensive. That means there should be expertise available all the time in the ICU to see about all the echo windows and all. So coming to the another test, that is passive leg rising test. This is not a static or dynamic measures of fluid responsiveness. This particular tells us test is like a auto fluid challenge test. What we do in this particular test, that we initially put in a patient in such that patient's trunk is a semi-recumbent position. We monitor a cardiac output in semi-recumbent position, and then we drop his trunk so that his legs are raised to 45 degree. And then again we see cardiac output. If there is increase in cardiac output, then again we make a patient in semi-recumbent position, and after calculating rise in cardiac output depending upon change in cardiac output, then we give a volume expansion, and we see that whether our patient, after giving particular volume, our patient has stabilized or not. This particular passive leg rising test has an advantage because we can do this particular test in a conscious patient, self-breathing patients, or patients is having arrhythmia. So all those who are contrary indications for PPV and SPV, this particular test can be done in those group of patients. Only contraindications are like patient should not have cervical spine injury. There should not be a rise in intra-abdominal pressure. In those group of patients, we have to avoid it. And this particular test has a mechanism of auto transfusion. All the blood from leg or pelvic vein goes into the right side of the heart, which is around about 300 to 500 ml. And then that increased venous return after rising legs causes a auto fluid challenge. And this auto fluid challenge, after we can calculate that on the basis of cardiac output, and then we'll see how much is a rise. So this is very beautiful test we can do in our ICU group of patients. This is a particular video how we do it. Usually this particular test require a special beds, and so that we can make patients semi-recumbent position, and then after we can drop his trunk to the horizontal. So this is a very, very short video how we do it in ICU. So this is an operation theater table. Initially, we'll make patient 45 degree up, that is propped up. And then we apply the cardiac output monitor in place, and then we see how much is cardiac output. After that, we put patient in a such a way that his trunk is horizontal and legs are raised to 30 to 45 degree, which causes like increased venous return from the leg and pelvic veins, and that causes a auto fluid challenge test. And then we again see monitor the cardiac output. So again, it has prerequisites are cardiac output monitor, bed. We should have a proper bed which can do this particular maneuver. We have to remove stockings, otherwise the venous return will not increase. Intra-abdominal pressure less than 16 millimeter. And what are the advantages? As I mentioned, we can do this particular test in a group of patients who are having arrhythmia, spontaneous breathing, sedation, even patient on like sedation, not on paralyzing agent, even those group of patients we can do it. This is a nice editorial published in 2024 where they have they mentioned the use of echocardiography to predict fluid responsiveness and manage of fluid, and they have mentioned that various studies or various cardiac windows wherein we can see whether our patient is fluid responsive or not, like transapical four chamber view, transthoracic echocardiography, looking for the contractility of right ventricular as well as left ventricular give us idea. This is again VTI variations will give us idea about whether our patient is fluid responsive or not. And IVC variations, the superior vena cava variation also give us certain idea about whether our patient is fluid responsive or not. So definitely TUDUCO has a very good and very important role while managing patient in ICU to monitor the fluid responsiveness. Passive leg rising test has also, along with VTI, it has a very good result to predict fluid responsiveness. So just like a very short training, or for that matter, very limited study of this 2D echocardiography, we can have how is our RV, how is our LV, whether the LV is kissing type of ventricular, hyperdynamicity of ventricle. On the basis of that, we can definitely monitor our patient, whether patient is preload responsive or not. So as I have already mentioned that being a preload responsive is not same as requiring fluid, because all of us, if we would have a cardiac output in place, we all will be like fluid responsive. Our all the SVV, PPV, we all be like fluid responsive. That doesn't mean that we need fluid. So fluid responsiveness only when we have to have certain targets like obtaining certain markers of perfusion. If patient's output is adequate, patient's blood pressure, mean arterial pressure, urine output, and pulse rate, if all other parameters are stable, then there is no need of chasing just values of, for that matter, CVP or IVC. So preload responsive doesn't mean that we should give fluid. We have to have some target in our mind before giving fluid. And good clinical examination is must, because as I mentioned, my first case, when young patient, obvious hypotension because of fluid loss from the GI tract, we should not require any gadget to monitor this group of patients. We should directly give fluid to this group of patients. Do not waste time in checking fluid responsiveness in obviously hypovolemic patients. Understand the limitations of each test and apply appropriate monitoring. Only patients who are likely to show significant benefit with increasing stroke volume without much risk should be given fluid. And all attempts should be made to limit the volume of fluid administration, because hypervolemia is also dangerous. Thank you.